Coming up on today's morning medical update, Bruce Willis's new diagnosis, what frontotemporal dementia means. We just cheered on the Chiefs. Now, health system docs are busy with baseball. We go live to Surprise, Arizona, as the Royals get their first physicals. Plus, the new app giving cancer patients more options. Enrolling in a clinical trial just got easier. How patients can help push science forward. And good morning. It is Monday, February 20th. I'm Jessica Lovell. Welcome to the Morning Medical Update. Last week, we promised to bring you the story of a bride-to-be who paused her wedding planning for a heart surgery. However, our patient, Kaylee Patterson, her docs were needed elsewhere this morning, so we will share her story sometime in the near future. But let's start this morning with our morning rounds. And we have an update on actor Bruce Willis. You may recall last March, the 67-year-old star retired from acting due to a speaking disorder called aphasia. His family has now revealed Willis has since been diagnosed with something called frontotemporal dementia. Joining us live now this morning is Dr. Jeff Burns, a neurologist and co-director of the KU Alzheimer's Disease Research Center. Dr. Burns, good morning.
Good morning. Thanks for having me.
Always good to have you on the program. What is the difference between aphasia and this new condition that we're going to call FTD?
Yeah, so aphasia is a language problem that can be caused by a lot of different things. Stroke being the most common one, where somebody has trouble after having a stroke, producing language or understanding language. And FTD is actually a neurodegenerative disease. It's in the family, related to Alzheimer's disease, neurodegenerative disease. And aphasia can be one symptom of FTD. And so in Bruce Willis's case, it appears that his early symptoms of FTD were this progressive aphasia. But FTD affects a lot more than that. It actually affects the front parts of the brain, and so we can see a lot of behavior and personality changes. Everything about a person can change, and it's a very devastating disease in that way. And then it can also affect language as well. So it's a progressive disease that really strikes actually younger people than, say, the average person with Alzheimer's disease. Tends to hit people in the 40s, 50s, and early 60s on average. So the answer to your question is, in this case, aphasia was probably an early symptom of his FTD, of his frontotemporal dementia.
So then how is it diagnosed? As you're following somebody with the aphasia and then it moves into dementia, how is it officially diagnosed where you can say this is what it is now?
Yeah, so a lot of our diagnosis is based on the signs and the symptoms that we're seeing, and then brain scans can be very helpful. So we'll do an MRI scan, and sometimes we can see the changes that we see shrinkage in the front parts of the brain, as opposed to an Alzheimer's disease, we tend to see it towards the back of the brain. And then PET scans can be helpful. PET scans, which look at the metabolism of the brain, and we can see changes in the frontal parts of the brain versus in Alzheimer's, where we might see it towards the back of the brain.
We know diseases of the brain, they're so tricky and hard to understand, but how is it treated? Is there any treatment?
Yeah, for frontotemporal dementia, we generally work hard to try to manage the symptoms. These behavior changes and the personality changes can lead to a lot of sort of what appears to be psychiatric problems, and are often treated by psychiatrists for years, sometimes before they're diagnosed. But the treatment of FTD is pretty limited. We try to help with some of these troublesome behaviors, and then we're working hard on developing new treatments. In fact, we have one clinical trial here for patients with frontotemporal dementia. It's sort of a specific type of patient with frontotemporal dementia who has a genetic mutation, a specific genetic mutation that we look for. And if somebody has that, we enroll them in this study, testing a new drug. So we don't yet have drugs that slow the disease process itself, and we just work to help manage the symptoms and the problem behaviors and help the families cope with these devastating changes.
Well, that was my next and last question, was just any advice for families entering into this world of unknowns?
Yeah, I mean, it's tough. I mean, it's, this disease is it's devastating. It's rare, but it hits people usually in their, in the 40s or 50s, at a time when they're still working and may have kids in the house. And it's a devastating condition. I'd say find help, and there are support groups. There's a FTD association, and then there's specialist centers like ours where we do see these patients fairly routinely, even though it's a rare disease.
Dr. Burns, always great to have you on. We appreciate your time this morning.
Okay, thank you.
Thank you. Future medical achievements, as we know, like a cure for dementia or a cure for cancer, rely on patients willing to take part in studies and clinical trials. Every day, people, they get the chance to advance the field of medicine, and sometimes they get first dibs on life-changing treatments. To help us learn more, we are happy to have Dr. Ron Chen, who wears many hats here and around the health system, clinical service chief at the University of Kansas Health System. He is chair of radiation oncology at the University of Kansas Cancer Center, and most important for today's discussion, he is the Associate Director of Health Equity at the University of Kansas Cancer Center. I always have to take a deep breath before I introduce you.
Good morning.
Good morning. Also with us, we're so glad to have Dr. Dinesh Pal Mudaranthakam. He is Director of Research Information Technology at the University of Kansas Medical Center. He is also an Assistant Professor at KUMC's Department of Biostatistics and Data Science. So thank you both for being here with us this morning. Happy Monday. Glad you could make it. Dr. Chen, let's start with you, because most people understand going to see a doctor for a checkup. We know that. We go see our doctors. But help us understand when a doctor's appointment turns into presenting a clinical trial. What might someone be entering into when they enter the world of clinical trials?
Great. Well, as a cancer doctor myself, every day I'm seeing patients who have often newly diagnosed cancer, and they're looking for recommendations on what options that exist for them. And here at the KU Cancer Center, being one of the large academic cancer centers in the country, not only do we offer traditional treatments for cancer, but I think one of the options that we also present to patients is clinical trials, the latest drug, the latest radiation treatment, the latest options that patients can consider, so to think about as one of their additional options. So I think oftentimes for patients are seeing here at KU, they're presented with various options, including considering clinical trials. And we have clinical trials available for many, many, many cancer diagnoses that are available. But also, clinical trials may not just be on treatment. There's also clinical trials looking at screening for cancer. In fact, we hope to be participating in a new screening test for cancer, and that may just be a blood test to screen for multiple different cancers. Looks very exciting. So there could be screening clinical trials. There could also be clinical trials looking at survivorship issues. So now that you're done with cancer treatment, how can we better take care of you to upkeep your overall health? So there's a variety of different kind of clinical trial options that the doctors would discuss with you during the consultation.
And on this program, we like to demystify the idea of clinical trials, because they can be such an important part of someone's treatment path. When we hear about trials, we talk about phase 1, phase 2, phase 3, and beyond. Tell us what's happening in those phases.
Yes, so phase 1, 2, and 3 trials often are talking about treatment trials. So phase 1 is when a drug is being used in humans for the first time. So very, very, very early experience for a new drug. And what they're trying to do in the phase 1 study is to see whether it's safe in patients, and also they will try to increase the dose to see what kind of dose would be safe and may be effective. So phase 1 is a very early trial, maybe the first time it's being used in humans, and oftentimes patients maybe at the very end stage and they don't have any more options, might consider doing a phase 1 trial as a Hail Mary to see if something might work for them. But really it's meant to be sort of a safety testing for a new drug. Phase 2, once a drug makes it through phase 1 and we understand that it is safe and we have a dose that we can use in patients, then phase 2, we will take that drug and use it in a few more patients, maybe 50 to 100 patients, to sort of get an early assessment of how effective it could be. You know, what percentage of patients have a response? Does the tumor shrink? How long does the response last? So phase 2 is an early assessment of how effective it is. And phase 3 often is the last phase, where now this drug is ready. It's shown to be kind of of effective and certainly safe. Now we're using in phase 3 is really comparing a new drug to a standard treatment to see if this new drug can beat the standard treatment as a new standard of care. So phase 3s are really, really exciting, and if phase 3s are positive, then we have developed a new drug into a new option for patients. But it has to go through phase 1 and phase 2, some of the earlier stages, before it gets there.
So are different patients brought in for different phases, or would one who enters in at 1 go through 1, 2, 3, and beyond, or sometimes somebody might be better for phase 2 or phase 3? How does that work?
Yeah, we usually, so here at KU Cancer Center, we have all phases of trials available. We have phase 1, phase 2, phase 3. Now, each phase usually takes several years to complete. So for a particular patient, they probably would be presented with options and probably join a trial if they want to and go through that trial. It would be pretty unusual for a patient to participate in phase 1 and then phase 2 and phase 3, just because of how long each trial would take.
So they can enter in at any time in which that treatment is needed for that particular patient.
When the trial's available in the different phases, yep.
Perfect. Okay, Dr. Mudaranthakam, very exciting. Your team has created an app to help cancer patients find clinical trials, because that can be tough. Who would, you start diving into the Google searching, into the internet, it's like, where do you find these trials? So why might someone use this particular app right there at their fingertips?
Well, the app, the intention of building this app was to help our physicians, first of all. And in 2021, we had launched the app purely targeting our physicians. But recently, a couple of weeks ago, we have launched an app which provides information for patients and their family members. So in other words, I could say this app would act like a Tinder, per suppose, but more or less for matching the clinical trials with the right patients. At the end of the day, still a physician would look at whether the patient would fit into the clinical trial or not. But a patient or a family member could express their interest if they want to participate in a clinical trial by just clicking on the app and signing up themselves for the clinical trial.
And I love how you called it Tinder. Tinder for like Match.com for matching you up with a trial.
Right.
Okay, we can get behind that. Okay, so how does this app work? You're going to actually show us on the screen.
Yeah, so as Dr. Chen had mentioned, precisely the clinicaltrials.gov houses only treatment or therapeutic trials, but what we have emphasized here in the app is to also present preventive screening related trials, as well as the quality of life trials, which is post cancer recovery. So anybody who wants to find an app could just go to the app and then they can navigate and find a trial that fits based upon their profile. And then once they find the trial they think is appropriate by reading the description of the trial, they can even look up and see where this clinical trial is available, at which site. If they're probably far off, living in the rural location, they can even see if there is a location near to their house and find out if that is their best location to enroll at that particular location, such as like Hayes or Topeka, or even the University Health. But the key piece is there are 2 buttons that we recently added, which is a game changer, if you would like to say, because they can either sign up to request more information, or they could also just send their interest in an email, and our nurse navigator would directly engage with them and try to get them screened for the trial that they have expressed interest.
So you just put in KUCC Clinical Trial Finder. I just tried it on my app here, and all I did was put in KUCC and it popped right up. That is super easy. And then just hit it. There it is. KUCC Clinical Trial Finder. I just got it. So we're going to put that information, we'll keep that up on the screen for you all to get. But Dr. Mudaranthakam, there's already a website, though, for finding clinical trials. You can go to ct.gov if you don't have a phone to get those apps. But why might this app be better than the website?
Well, the ct.gov gets updated once a week or twice a week, depending upon what phase of the study it is in, like whether it's open to enrollment or is it currently in follow-up, and inclusion-exclusion criteria are listed there, and then the contact of the study is listed. But the app actually navigates you and tries to showcase only those limited study. Again, going back to my analogy of Tinder, if I'm looking for certain characteristics in my partner, I want to plug those in and be able to identify my short list rather than the whole gamut of 100 studies, right? So that's what the app does compared to ct.gov, and also it refreshes on daily basis. The coordinators and the physicians who are here at the ground level are updating the status and ensuring that the right studies show up. So that's the beauty of it. And then they get directly in contact with a navigator. So instead of emailing in the dark or trying to call somebody or cold call somebody, they're emailing to the right screening member. So that way they can pair up and then start the next steps, which would be screening.
And this was your brainchild, but this took a big team to pull off. Right?
Absolutely, and I wouldn't have been able to achieve this without the help of, first of all, the great leaders, starting from Dr. Jensen, Dr. Chen, and our community leaders, and especially the Pivot members, our patient advocacy group, who have guided us at every step, and they were the ones who had given us input at every step, suggesting which buttons would be appropriate, and how should a patient navigate, and how do they think, because I'm a technologist, I'm a data scientist, but at the end of the day, they're the ones who have gone through this and experienced it, so they are best at it, and they know what they have experienced. So they have guided us throughout. So without them and without our technical team, we wouldn't have been able to get this rolled out.
Dr. Chen?
Yeah, I just want to chime in from a physician's perspective on this app. I really think it's an incredible resource for patients and puts the power in the patient's hands. You know, let's say you have breast cancer or prostate cancer. You've had some consultations, you've heard about the options, but you're wondering if there's clinical trials that are available to you. You can look into this app, look at breast cancer, look at prostate cancer, and there will come up with a short list of trials that could be suitable for your diagnosis. And so you can look through that and either ask your physicians about it or use the app to get connected to actually the trial team to ask specifically about that. So for patients who are out there anywhere watching this and they're wondering clinical trials, this app really makes it easy to see if that's an option for your treatment.
And remind people how successful the trials are, not just on the research level, that's great because that advances us forward, but also for the patient and their treatment and their diagnosis.
Yeah, I think the trials, clinical trials is how we make huge progress in cancer and every other disease. I'll just say that last week I was in San Francisco for a major cancer conference, and there were multiple presentations of positive clinical trials that's now going to change the standard of care in prostate cancer and bladder cancer and kidney cancer. These trials, I mean, just hearing about the positive trials, increasing survival, increasing cure rates for patients, every year there's positive trials that's going to make the standard of care even better. It's very, very exciting. You know, clinical trials is how cancer screening was proven to improve survival. PSA screening, mammography screening, it really takes clinical trials to show something is working and for us to advance the diagnosis and treatment for patients.
But Dr. Chen, there is one big problem with clinical trials, and that is a lack of diversity. Most participants, they're white men, and we've talked about that, right? We need more diversity. But there is one local artist who is hoping to help the community visualize what is missing with the power of color.
Thinking instead of a heart, I could do a pink ribbon.
Okay.
Local Kansas City artist Vania Soda connects with her Kansas City muse, breast cancer survivor Kim Jones.
I never thought I'd see my face on the side of a building.
Her face now a part of the Kansas City landscape and symbol of healthcare equality.
Kind of like a time capsule to then be able to make my mark whenever I'm no longer here, that, you know, I used my own journey and situation to try to do as much as I could to try to help those that are going to come in behind me.
It's a different kind of message of hope in a different way, I think, celebrating the people that has lived through it.
Soto is using her passion for paint in a big way, helping to put a face to what's missing in cancer research.
I feel like if the same race and group of people people are the only ones going through these clinical trials, there's no way that we could advance the cure for cancer. I think using murals as a way of storytelling is really powerful.
And it's an important story to tell. The FDA reports 75% of clinical trial participants are white.
They're going to come and ring this bell.
Dr. Ronald Chen is Associate Director of Health Equity with the University of Kansas Cancer Center that partnered with SOTO to reach this diverse community.
The picture is really designed in collaboration with the community, and it means a lot to me because it shows representation, and that's what we want to see reflected in clinical trials as well.
Chen says there are two big issues.
One, oftentimes clinical trials provide patients access to the latest treatments that are not yet available to everybody, and so it could actually be the best option for some patients. I think the other really important issue, many clinical trials have only less than 5% of enrollment of underrepresented minorities, and that's a big problem.
A problem SOTO hopes her art will help conquer in the community she grew up in and beyond.
The impact is greater outside of just this community because it is done by hand. So it gives it more passion and more awareness of the importance of the message.
Great story, Dr. Chen. I'm so glad we are all a part of that. I want to talk about why diversity in clinical trials are so important. And are we just talking about race and gender? We talk about that a lot, but is it also age or pregnancy status, disabilities? Does it cover everything? What are we needing more of?
Yeah, I think there's two important issues about diversity in clinical trials. One is access to clinical trials, because I think clinical trials often represent access to the latest promising treatment in cancer, for example, and we really need a lot of cancer patients to have the good access to this option. And in that sense, diversity can mean a lot of things. You know, if you are a cancer patient, you may be wondering, well, why am I not in a clinical trial? Why is it not accessible to me? In that sense, diversity could mean that you're living in the rural area and you don't have access to a local cancer center that offers clinical trials. It could mean race. It could mean gender. It could also mean that you have some other medical problems. Maybe you have heart disease, or maybe your kidney's not perfect, your liver's not perfect. And sometimes, historically, clinical trials have excluded patients who are not young and the healthiest possible. Historically, clinical trials have selected the youngest and the healthiest patients, so there's the most possibility for a trial to be positive. But that also means that if you have, you know, a little bit of kidney failure or a little bit of liver disease, you may be excluded. And I think those are all really important issues that prevent patients from accessing this great option. I think there's increasing awareness that that's a problem. I think the other issue about representation is once a clinical trial is done, if the trial is positive and the result works, does it really work for everybody? And so clinical trials often report if the cancer treatment works, what kind of side effects it causes. But if you're only including the youngest and the healthiest patient, when you're using this new drug, now the trial's positive and it's FDA approved. If you're using it in slightly older patients who have a little bit of other medical problems, is it going to cause more side effects? And if the trials don't include all patients, all different types of patients, then we don't really know the efficacy and the safety of the new drug to all different kinds of patients.
So come one, come all.
That's right.
All right. So if you have questions for our clinical trial experts here on the panel, make sure you send them to us on YouTube, Facebook, and the Medical News Network. You can find links to all of those right there on your screen. But let's get a check of our COVID count with Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control. Good morning.
Hi.
Happy Monday. How are you?
Good morning. I'm good.
Good.
Yeah, right now we in the hospital, we still have 58 total infections, but 38 active infections, 11 of those in the ICU, and over the past week we did see our ICU numbers go up as well. 4 on the ventilator. You know, 38 active infections. I think we were at 26 or 27 on Friday. Some of this could be some reporting issues, administrative issues, as we look to see who has been here and see if we can count those in the actual recovery period. But I think for the most part of last week, we were really sitting on that mid-20s, 26, 27 active infections. So we'll see what the next couple days bring as far as that goes.
So Doc Hawk, you took an interest in some new findings about treating COVID patients. As published in the journal Lancet, researchers asked if the novel coronavirus would rebound in patients after they got antiviral drugs for 5 days. Now, why were researchers asking that question? And of course, what did they find?
So we do know viral rebound happens. You know, it is most public now with SARS-CoV-2 infection, but we know it happens with other viruses. And what we're talking about is a rebound in those symptoms. You have the illness, you get better, and then maybe 7, 10, 12 days later, you start to have symptoms again. You also have viral rebound, so you have some more replication of that virus. And so people have been really concerned about that. The early studies of Paxlovid showed that that did happen. We know that in the real world, people who don't take those antivirals or that antiviral, it can happen as well. This was one large, well-done study that showed that really the amount of people who have that rebound with symptoms or virus is about the same if you take Paxlovid or you don't take Paxlovid. But the important thing about that is, for those people that are at highest risk, Paxlovid continues to offer very good protection against hospitalization and death. And that is very important because some people have a fear of that rebound, but really there's been no severe illnesses with that rebound. And overall, if you are a candidate and you are high risk for severe outcomes, it is vitally important to be placed on Paxlovid. It still works. It still does help reduce your chance at hospitalization and death.
Doc Hawk, thank you so much.
Yeah.
We head down to Surprise, Arizona now as we turn our excitement to the 2023 baseball season. Dr. Vincent Key is up early with us this morning. He's an orthopedic surgeon for the health system and head team physician for the Kansas City Royals and past president of the Medical Advisory Board for MLB. Dr. Key, good morning. How are you?
Good. How are you?
I'm good. Good to see you, and thanks for being with us. So we know this past weekend, the Major League roster went through its physicals. Tell us a little bit about what that entails. Are those the typical physicals that the rest of us get, or are they a bit more intense?
They're a bit more intense, but for the most part, they're what everyone else gets. Meaning that you just get your general medical physical. You get, obviously our guys get an orthopedic physical from me. We do screening, oral screening. We do eye screening. Obviously, guys need to be able to see to hit the ball or to throw the ball. We also do echocardiograms here. So it's really intense, and from that standpoint, it's very thorough and comprehensive.
So, Dr. Key, the team reports to practice this week coming out of the off season. Injuries could be a concern. What injuries are players most prone to coming out of the off season? What are you particularly looking for?
Well, initially coming out of the off season, they get these type of injuries sometimes by training too much during the off season, and then they're a little fatigued, and then they get into this, and then all of them get very hyper competitive. So you get some fatigue injuries, sometimes, whether it be shoulder, whether it be elbow, whether it be something like your oblique. Sometimes you'll get those type of injuries. So it's a matter of management once these players get here in terms of, not trying to ramp up too much, too fast, too soon. So that's what we really talk to them about, is really easing into spring training as opposed to going 0 to 100.
What's your advice for the young athletes coming out of the off season as well? They have big dreams of the big leagues. How can we make sure to keep them fit and healthy?
Well, I think the biggest thing is being proactive instead of being reactive, meaning this. Usually the way that I do it in terms of baseball is that high school tryouts are usually the first week in March. And so if you're a pitcher, you should have been starting to get yourself ready to go actually January 1st, meaning you're doing your stretching consistently. Everyone will tell these players to get strong, but hardly any of them tell them to get more flexible. If you're a position player, then it's usually the second week in January, which gives them about 6 weeks. Pitchers, you give about 8 weeks to get ready to go. Getting your hamstrings right, being able to manage your body, get your body ready to go. Because, like I said, whether it be from a high school perspective, college perspective, or even the professional ranks, you try to go from 0 to 100. And if your body's not ready for it, then hopefully it doesn't happen, but sometimes it will happen that injuries crop up.
Hey, Dr. Key, before I let you go, first spring training game is this Friday. What excites you most about the upcoming season?
I think the biggest thing is that there's been a little bit of a change, obviously, with our manager and coaches and things of that nature. It's a little bit of a different energy. It's a good energy. Guys are ready to go. Guys are ready to compete. We've got a lot of new players, pitching and position players, and I think if we can get this group to gel together, I think we're going to actually surprise some people this year. That I think, in my gut, I think we're going to be a lot better than what people think.
Well, we like to hear that. All right, Dr. Key, thank you so much.
I appreciate you.
Have fun down there. We'll see you soon. All right, do we have any reporter questions on the line today? Let's get to our viewer questions. Angie wants to know, is there any charge for the app?
No, the app is absolutely free. There is no charge whatsoever. And anybody could just go to the App Store and download the app, and it will just install. And in case in future, if we make any changes or optimization, that will alert them on their phone saying there is an update to the app.
And again, it's KUCC Clinical Trial Finder. I just pulled it up. It was super easy to find and download. So, Dr. Chen, Eric wants to know, can you give us an example of a treatment that might work differently based on age or race or gender? Have any findings, anything that we know of, or any particular area of medicine that works differently?
Yeah, absolutely. I mean, I think that the most obvious example is that many cancer treatments work differently based on age. For example, if you're thinking about chemotherapy or radiation therapy or surgery, treatment is likely to cause more side effects, maybe in older patients and patients who have other medical conditions. And sometimes it causes such side effects that you will have to stop treatment early before finishing, and therefore it doesn't work as well. So really having clinical trials that incorporate not only young, healthy patients, but also older patients with some other health problems really help us understand that issue.
And Bob asked, is it just new drugs that get tested, or is it other things? You mentioned screening.
Yeah.
So tell us about that.
Yeah, absolutely. I think there's all sorts of different clinical trials. I think treatment is the one that we think about most often, but there are new screening tests that are being tested that's going to be even better than what we have today. What I mentioned is maybe a new blood test that can screen for a variety of different cancers, maybe in the future replacing colonoscopy, replacing mammography, replacing PSA, just have one blood test that can screen for a variety of cancers. I mean, sounds promising, but we have to go through clinical trials to see whether it actually works. I recently led a national trial looking at survivorship issues. So patients after cancer treatment may have sort of long-term side effects and may neglect other problems that they have. So looking at how we can sort of increase our survivorship care so patients really follow up with their heart disease and manage their side effects, how we can better take care of them. Those are all sorts of clinical trials that are potentially available.
Megan wants to know, she said, what is KU Cancer Center doing to try to get more diversity in clinical trials? We saw the beautiful mural that we teamed up with on that local artist, but what else are we doing? I think people want to see what kind of action is being taken, and how can us as community members get the word out?
Yeah, I think that's a really good question. I'm going to start, and I want to pass it over to Dinesh as well. So there's a variety of things. I think one of the concerns that some patients have about clinical trials is, one, I don't want to be experimented on. I'm a patient. I don't want to have be an experimental guinea pig or something. I think that's a concern. And people are concerned about the safety and also ethics of clinical trials. I really think that those concerns can be alleviated. A lot of clinical trials nowadays are comparing standard treatment versus standard treatment plus a new drug. And there's no way to lose as a patient. You're either getting the standard of care or standard of care plus something new, and that something new ends up being positive. You've gotten even better treatment. Right. And I think really being able to consider those options where you can't lose as a clinical trial participant, and understanding that clinical trials have gone through now multiple rounds of ethics approval to really to open to be accessible to patients. I think that's important to understand. The other thing that I think we're doing as a cancer center is we're actually tracking now patients who are enrolling to see whether we have good representation. And Dinesh's team actually really leads the effort on that. So I want to give him an opportunity to talk about this.
Yeah, thank you, Dr. Chen. as some of our initiatives, primarily what we do is we track every patient that is being screened, as well as every patient that gets enrolled onto any of our trial that is open here at the Cancer Center, as well as our community partners. And what we do is monthly we summarize these metrics and present it to our equity team to figure out how well we are doing, because we need to lay some benchmarks and some standards in order to improve on our metrics. So that's the first step what we do. And then secondly, as part of our few initiatives, we have started surveying our patient community and have been asking for their perception. What do they think about clinical trial, and are they willing to participate in future clinical trials, and how do they obtain the information about clinical trial? So we have looked at these responses. We are glad to report that we got roughly around 700 people taking this response who are residents of Kansas living across the state, and there is a lot of interest through the responses, that's what we could say, and they're willing to participate. So that is key. And I want to remind, these clinical trials are being open and made available in the best interest of the patient. So patients can always have those conversations with their clinical provider to see what fits best to their profile, and then they can always enroll and discontinue if they didn't like it. But also keep in mind, every treatment that's available today out there was at some point a clinical trial. So if those treatments wouldn't have been tested, today we wouldn't have had that opportunity to extend that service to the patient. So it's not just about them, but it is about the community. They're helping the community and helping find new groundbreaking drugs. So that is key here.
And of course, the app is putting the power back at the patient. And Dr. Chen, you've said before, it's a team effort. Don't just wait for your doctor to bring the trial to you. You can bring the trial idea to them as well. Just before we go, Joellen had a comment. Joellen, good morning. Thanks for watching. She says, I feel age is a big barrier to everything medical. Treatment, options being written off due to normal aging issues, access, transportation, less technology skills, advocacy. The list goes on and on. Is age a big barrier? Is it getting better, or as we go on, is it worse? Where are we seeing the biggest dips?
I do think that it's getting better.
Okay.
I think maybe 10 years ago, clinical trials really were selecting for younger patients and even had an age restriction above a certain number, 70, 75, you are not eligible for some of these clinical trials. I think now there's increasing awareness that that is wrong. We really want older cancer patients to have access to clinical trials. We also want to make sure that these new treatments are safe for older patients. And so I really think it's getting much better.
Yeah, and I think, somebody of an older age, that could be their legacy, entering into a trial and, again, advancing medicine, which is what we're always trying to do through research. I want to get final thoughts from our guests, and Dr. Muruganthakam, I'm going to start with you.
Sure. I just want to say, this is a great opportunity to participate and take the advantage. Clinical trial, access to clinical trial is, again, a great way to ensure that your involvement and your representation is shown through the community, as well as this is an option to overcome some of the financial burdens, because clinical trials, some of the treatment that is being provided is being paid by either the sponsor or the pharma. So why not take the opportunity and try to benefit by participating in the clinical trial?
And I just have to jump in with Ann Burley's comment, Dr. Chen, before I let you go, which she says, how can I provide clinical trials to those, how can we provide them to those living in rural areas? And I know apps like this help get the word out, but how do we get access? How do we get that transportation? How do we get them involved?
Yeah, that's a great question. Actually, I was going to, I want to really give a shout out to the Masonic Cancer Alliance. So KU Cancer Center, understanding that rural patients may have a hard time accessing clinical trials, we have the Masonic Cancer Alliance, which is really a group of cancer centers throughout Kansas and western Missouri. In the Masonic Cancer Alliance, these local, smaller cancer centers can offer the clinical trials that we offer here at KU, but patients can be treated closer to home on these trials. So really, I think this really helps some of the rural patients, maybe in western Kansas, have access to clinical trials that we offer, but getting treated closer to home.
Yeah, I had to ask that question. With a state like Kansas, where you have so much out west, I want to make sure that people have access and know about this app and know the work that we're doing. Last final thought, Dr. Chen.
Well, I gave a shout out to the Masonic Cancer Alliance. I also want to give a shout out to Kim Jones, who we saw in the video, but also our community partners throughout Kansas and throughout the Kansas City area. Our community advisory board, our pivot partners, these patient advocates really help us as cancer center leadership understand how we can serve patients better. They really also help us get the word out about clinical trials and help us understand how we can better provide clinical trials to patients across Kansas and western Missouri. So I want to give a shout out to Kim, Pivot, and all of our community advisory members.
And shout out to both of you. Thank you so much for the work you do and being here with us this morning. Dr. Hawkinson, final thoughts.
Yeah, I mean, I think what else is there to do than echo on what our guests have talked about. The clinical trials are so important for everything, especially for this. And I think it is a great thing that we can help provide further access to these. So please download that app, and hopefully it, ultimately it will serve somebody in the future, whether it's right now or because of all the information we gain from that. So it's vitally important.
Thank you all for being with us today. We will see you back here tomorrow at 8 a.m. Coming up tomorrow on the Morning Medical Update. It was a crazy busy Christmas week. How did doctors pull off 4 heart transplants in just 36 hours? I'm Jessica Lovell on the next Morning Medical Update. Meet the doctor who helped pull off this holiday feat, plus one woman who got the special Christmas gift of life. Tuesday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stein's podcasts. Now, everywhere podcasts are available.